Okay, this is our ultrasound course, and today we are continuing the gallbladder lecture. We have discussed before the normal anatomy and the abnormalities and the gallbladder stone. Today we're going to continue our journey with the gallbladder, and we are starting with the acute cholecystitis. Now, before we tackle this, make sure that you have your coffee. Okay, I have a nice picture of our coffee here. By the way, coffee English comes from the word qahwa, qahwa in Arabic, qahwa, coffee. Okay, because it was first known in the Arabian region, and the mocha, the famous name for the mocha pot, the cafetiere, the Italian cafetiere, is named after the port in Yemen or in Habasha. And if you love coffee, you would know that from these parts produce one of the best coffee beans around the world. So uh, make sure to have your coffee, whether it is like this or filter or whatever, or espresso. And let's sail on in our journey with the acute cholecystitis. The acute cholecystitis is, we have to differentiate it from the gallbladder stone. Yeah, they're closely related because in 95% of cases, the acute cholecystitis is caused by gallstone. However, it does not almost always mean that the patient has gallstone. As we would see, there are conditions which the acute cholecystitis can happen without stone. Yes, in 95% it's related to stone, but not always. And also, the gallbladder stone does not necessarily mean the patient has acute cholecystitis. So, what is acute cholecystitis? As we know, itis means inflammation, okay? And this part means gallbladder. Cholecyst means gallbladder. And acute, the condition being acute. So this is the condition in which there is inflammation of the gallbladder and the patient is in acute phase. Okay, he is suffering, he has symptoms. Now, what are these symptoms? Let's see. The patient suffering from acute cholecystitis would be in pain. This is important. Now, where would that pain be? In the right upper quadrant. Let's suppose that this is our patient. Of course, you know that my drawing is not really the best, not your Van Gogh. So, supposing that this is our poor patient, he would have his pain here in the right upper quadrant. Okay? But of course, as we all know, that this region is not specific for the cholecystitis. We have other differential diagnoses that we know. Usually, you would have referral from the surgeon or from the GP or whatever who have seen the patient first that he is suspecting acute cholecystitis and other things as such, like the peptic ulcer. This is very common to also cause this, the stomach problems, or duodenal ulcer, or gastritis, and all this. Pancreatitis, hepatitis, especially in children, appendicitis. Appendicitis, of course, is known to cause lower quadrant, right lower quadrant pain, uh, much lower, near the area fossa. However, it can also radiate to the upper quadrant. Okay, hepatic congestion, right lower lobe pneumonia, as such. Okay, but most importantly, the acute cholecystitis and the peptic ulcer disease or duodenal ulcer. These are very common to cause pain in this age. Now, according to the Tokyo guidelines, okay, we have to have one criterion from uh, these three categories in order to diagnose the acute cholecystitis. Now, the point of this slide is to clarify very important points. The ultrasound by its own does not diagnose the acute cholecystitis. You have to know this. There has to be an element of the clinical picture in order for that you can suggest readily that this is acute cholecystitis. So bear this in mind. Yeah, the ultrasound is absolutely important. Okay, this is your role, but you have also to ask for the history. like the patient having pain, as we have described in the right upper quadrant, or tenderness that's elicited by the examiner or by the probe. Okay, this exists too. The positive nerve sign exists by the probe, as we would see, and this is one of our signs. Okay, also the fever, some labs like elevated white BCs, okay, or elevated CRB, okay, and of course our ultrasound. So there has to be more than one criteria in order to readily diagnose the acute cholecystitis. Now let's see. Okay, this is what we have seen. All right. Now, what about the sequence of events? Okay, let's see. The symptoms, the signs by the ultrasound and how they happen. Okay, we said that the acute cholecystitis most commonly caused by the gallbladder stone. Now, the gallbladder stone was here, for example, and then it moved to the neck. Okay, so first thing that we would find impacted stone. Okay, impacted stone at the neck. ماشي, okay, ماشي, we say this in Arabic. All right, so the impacted stone at the neck would make the gallbladder distend as such. Oh, it is obstructed. Thus, it would be distended with bile. And this would lead to the second point, distension of the gallbladder. Of course, we have to quantify this distension like what? Like it being, the width being more than 4 centimeters. If you remember from the first part, we said that the dimension of the gallbladder, it is 10 by 4. Absolutely right, 10 by 4. Now, the width here matters, and it has to be more than 4 centimeters so we can consider it being distended. Okay, now this poor gallbladder, it has obstruction ahead of it, and it is distended, so what will happen? The wall of the gallbladder, the muscular wall, would start to exert enormous effort in order to overcome this obstruction. Thus, this would make these muscles hypertrophy, so they would increase in thickness. So the third thing is increased gallbladder wall thickness. And if you remember, what was the cutoff for the gallbladder wall thickness? Absolutely correct. It is 3 millimeters. So it has to be thickened over 3 millimeters. And we measured what border? The anterior border. Absolutely right. So this will lead to hypertrophy of the wall and thickened. Now, if the wall is thickened, muscles are thickened, and the muscular mass is thickened, this would call for what? More blood supply, right? More blood supply. So this means hypervascularity or hyperemia of the gallbladder. This would refer to us checking what? The cystic artery by the Doppler, as we would see. Okay, now this inflamed gallbladder would do what? Hmm, absolutely right, would extravasate the fluid. And we would see very polycystic fluid, or even, and we would see abscess. Okay, and lastly, as we have seen in the previous slide, the positive nervy sign. This is important, very important. Now, when you're examining the patient by your probe, you'd find him saying, "Oh, please remove your hand." Positive nervy sign can be elicited by the probe or by the examiner's hand, or the patient would tell you that he has pain in this part. Okay, so this is the sequence of events and how it reflect on our ultrasound signs. Let's see them right away. How would they appear in the ultrasound? Okay, voila. These are the impacted stone, okay, whether in the neck or in the cystic duct, the positive nervous sign sonographic, that's to say, elicited by the probe, the thickening of the gallbladder wall, distension and the collection, and the hyperemia by the Doppler. Okay, so far so good. Voila, this is our picture. Here we have the stone impacted here, classical stone. Okay, this is the mud It is considered to be precursor of the stone, or it can, in this case, be pus too. Why not? It can be pus or mud. Okay, distension of the gallbladder. Okay, and look at this wall. Look at this wall. It is thickened. It is hypertrophied. It can also be appreciated here. Okay, and there is collection around the gallbladder or polycystic fluid. So these all strongly suggest that the patient has acute cholecystitis. So we write this picture suggestive of acute calcular cholecystitis because there is a stone here. Okay, again, the same. This is the stone. Look at this wall. Look at this wall. It's very thick, and as we see later, this pattern is straight because we have hypoechoic and hyperechoic and stuff like this, and this tension. Voila. Regard this width. Okay. With the history of the patient having pain, positive Murphy sign, all of this is highly suggestive. Look at this, is real time. Okay, you can appreciate here the stone, right? Appreciate the thickness of the gallbladder and the swirl of fluid around it. Okay, all of this highly suggest same. Another picture. Train your eye in order to recognize all of the signs. Okay, now this is very important. Okay, appreciating all of this, you have to note something. None of this above signs is pathognomonic on its own. And as we will see, there is differential diagnosis for almost all of these points. So none of them on its own is diagnostic. However, their presence together, more of one of them, the combination, okay, along with the clinical picture as we have explained, all of this strongly suggests, but none of them on its own is pathognomonic. You have to check them all. Okay, now let's start with the Murphy sign. Even the Murphy sign, it is not specific for the acute cholecystitis. What I mean here is that patient might have acute cholecystitis without Murphy sign. How is this possible? If he has, absolutely correct, if he has diabetes. Diabetes essentially affects the nerves, so he might not suffer from the classical Murphy sign or the pain as in the classical clinical picture, and also the nervated cholecystitis patients that are elderly, patients on painkillers, all of these patients will not have the positive Murphy sign. Okay, all right. What about the gallbladder wall thickening? Is it specific for the acute cholecystitis? Again, it's not. Here are the other reasons and other conditions in which the gallbladder wall can be thickened and it is not acute cholecystitis. Let's check them. So there are other causes that can cause the gallbladder wall to be thickened, as in general causes that causes edematous state. As in renal failure, as in hypoalbuminemia, as in hepatic failure, advanced cirrhosis, as in heart failure. All of these entail the general state of edema that will cause the gallbladder wall to be edematous and thickened without that being acute cholecystitis. The chronic cholecystitis, other causes related to the gallbladder. Okay, of course, the very famous hepatitis. Okay, so there are other causes, and the gallbladder wall thickening is not specific for the acute cholecystitis. That's why we said that the combination of the signs along with the clinical picture is absolutely important. As in here, okay, here we have thickening of the gallbladder, however, there is no history of pain. Okay, and the patient has ascites or renal failure. So here we wouldn't write acute cholecystitis. We just say that there is diffuse gallbladder wall thickening. Although there is stone here, okay, we would say that this is a gallbladder stone with diffuse gallbladder wall thickening, because I'm not sure that this is acute cholecystitis, and the patient has other reasons to suggest it, like the liver disease, like ascites, like renal disease, and he does not have the clinical picture of acute cholecystitis, there's in pain, there's in fever, as in leukocytosis. So in this case, I would just say that this is diffuse, as in here, diffuse gallbladder wall edema along with the stone, okay? But I wouldn't suggest the acute cholecystitis in my report if it was on its own and the patient had other causes that might cause the gallbladder wall to be thickened, okay? Again, if we suppose that this patient here has history of right upper quadrant pain, okay, and he has positive nervous sign, okay, has fever, leukocytosis, I would suggest acute cholecystitis. Although the stone here is not impacted, but it might have moved, and the gallbladder might have, distension might have been relieved. However, I have here more than one criteria. This is very important, that you have to gather the criteria together. If you have enough suspicion, you would write that this is highly suggestive of acute calcular cholecystitis. I have here the gallbladder wall thickening. I have here the stone. I have my clinical picture with the patient suffering. I have positive sonographic nervous sign. Okay, I would say that this is acute cholecystitis. If the patient doesn't have clinical picture suggestive or positive nervous sign, and he only has this gallbladder stone and the gallbladder wall thickening and other causes that would suggest, I wouldn't say acute calcular cholecystitis. I would say that there is a stone and there is diffuse gallbladder wall thickening. Okay, so it's important to be precise, okay, and that you gather the data and accordingly suggest your diagnosis. Okay, okay. Here there's the gallbladder wall thickening and the stones. My report will depend on the whole picture together. Okay, what about this? I have here impressive gallbladder wall thickening. Look at this, look at this. This is very impressive. This is what's called striated gallbladder wall thickening. However, there is no stone, and this is a child with history of vomiting and jaundice. This is what right away I would know that this is a clinical picture suggestive of hepatitis. So it is the combination of the signs along with the clinical picture that would make my diagnosis. Okay. Now, this is the patterns of the gallbladder wall thickening I was just telling you about. We have here three patterns, the uniformly echogenic, three layers here. We've got the sandwich with the central area of hypoechogenicity, this, and the striated pattern. Let's check them out along with the sonographic pictures as usual. Okay, let's see. First one, the uniformly echogenic. Well, this echogenicity, this echogenicity here, this echogenicity, uniform echogenicity, this white look of the gallbladder wall suggests right away the chronicity. Okay, so the uniformly echogenic, this process is being long enough, right, so that the gallbladder wall look as such. This is not acute. This is chronic. So the gallbladder wall thickening, as we have said, is not specific for the acute cholecystitis. If it is as such, uniformly echogenic, and the patient doesn't have pain right now, all right, then he has cholecystitis, but it is chronic. It is chronic, it is not an acute attack. Okay? If it looks like this, the patient have pain, then it is acute on top of chronic. Okay? All right. Again, here another pattern of the gallbladder wall thickening. We have here echogenic line, and echogenic line is central area of hypoechogenicity. Okay, this is more likely with edema. Again, the edema can happen with acute cholecystitis and other causes, as we said, general causes as in ascites, as in renal edema, as in heart failure. Okay, other causes that can cause edema, whether related to gallbladder or systemic. So this pattern is more in suggestion with the edema. Again, another picture for the edema, 3 layers. Here we can appreciate another pattern. Okay, this is striated because we have this echogenic and then hypoechogenic and then echogenic and then hypoechogenic, and the pattern repeats itself. Okay, so this pattern is like striation. Okay, and this is very impressive for hepatitis. and acute cholecystitis. Okay? So, I mean, the pattern can be suggestive, but as we have said, none on its own. Always we have to have the picture on its own. Again, the striated pattern. Again, the striated pattern here. All right, so back to our list. As we said, that none of them on its own is pathognomonic. As we have seen, that the thickening of the gallbladder can happen other. As we have seen, the Murphy sign can be negative if the patient has acute cholecystitis. The stone can be present without being impacted. Okay. Now, what about the pericholecystic fluid? We have two patterns. It can be localized or it can be around it. Localized is in here. And this pattern is around the gallbladder. Okay, as you can see. All right. And it can also form abscess. Okay, as we see in the liver lectures, that the most common cause of hepatic abscess is the cholecystitis. Okay, the pericholecystic fluid will organize and form abscess as such, adjacent abscess as such. Voila. Look at this gallbladder. Okay, it has very thick wall, and adjacent to it, it has an abscess. Okay, so this is cholecystitis with an abscess. Okay, so this is the pericholecystic fluid collection. It can be around it or it can be in the form of abscess. Look at the hyperemia. Okay, as we said in the first part, it's important to see the cystic artery. Now, this is the clinical importance. This is the clinical importance of finding it and adjusting your Doppler settings in order to see it. As we see here, this is the anterior branch of the cystic artery and it's hyperemic. Again, the same here. Okay. This also confirms the presence of hyperemic state, hypervascular state in suggestion with, okay, the acute cholecystitis. Look at this, where this stone here impacted. We have this hypervascularity. We have the thickening of the gallbladder and the pericytic fluid that has formed small abscesses. Okay, all of this is suggesting strongly the acute cholecystitis. Okay, all right. This is the case complete. Look at the stone impacted here. Look at the mud or the pus. Look at the thickening of the gallbladder. Look at the hypervascular cystic artery. Look at the fluid around it, the hyperemia, and the small abscesses. So these are all the signs of acute cholecystitis. Okay. Okay. Here we have another variation of acute cholecystitis without the stone. As we said, the stone is not conditioned in 100% of cases. Yeah, it is the most common. However, it can happen without a stone. Okay, but I'll tell you something here. If you see this, okay, please report it very clearly to your clinician. Okay. Linguistically speaking, when you see A as such, it means no, right? So this acute acalcular means that there is no calcular. However, in order to be crystal clear, you can use a more friendly term to your clinician, the very basic clinician. You can say acute non-calcular cholecystitis, okay? Of course, this is linguistically and medically right. However, you can say acute non-calcular in order to be crystal clear that there is no stone here, okay? These are the conditions where there is cholecystitis, but there is no stone. And yeah, it happens. Okay. When does this happen? When does this happen that the patient has acute cholecystitis and there is no stone? Well, it happens in gravely ill patient, okay? Patient that is in the ICU, patient that has a major operation, patient with major burn, big burn, right? So the patient here is not well. he is not well. If he is not hospitalized, he is an elderly patient. Okay, so this patient is very different from the one that's young, that's healthy, but he's in pain and he's suffering from pain in his right upper quadrant. This is the patient with the stroke. But this patient no, is different. This patient is ill. He has a major event. Okay, as we see here, we have the cholecystitis. The gallbladder is very thick wall, and there is fluid inside it. Okay, it might be uh, mud. Okay, but there is no stone. Right, this might be um, pus or anything, but this is not a stone. Okay, and this is hypervascular. Again, this is cholecystitis. Okay, without a stone. Acute non-calcular cholecystitis. All right. Here another example. Let's see. This is the striated pattern of thickening of the gallbladder, and this, as we said, this highly suggests the acute cholecystitis and the hepatitis. Okay. What about the complication? As we said, it is absolutely important to be precise in the report and that we will take care of this. Now we have differentiated between the gallbladder stone, okay, we just see stone, and if it has caused acute calcular cholecystitis, as we have said, okay, and we have also the entity of acute non-calcular cholecystitis. Now, if we have acute cholecystitis, it is also worth mentioning whether this is complicated or not. Then, what are the complications I'm looking for to tell the clinician if this is a complicated case or not? These are the complications: the hydropes, the empyemia, the gangrenes, the emphysematous, and the perforated. Now, let's see how would they look. Okay, all right. Let's see. First, the hydropes. What is this? It means that there is a huge distension of the gallbladder. How is this? The gallbladder here, okay, in our sequence of events, we have this poor gallbladder that is distended due to this obstruction. It would be very distended, and here we would rely on the length. If it is more than 10 centimeter in length, this means it is very distended, as in here in the longitudinal jet, it's very distended, okay, or even you can even consider being over 12, okay. This is definitely means that there is hydropes or mucocele on the gallbladder or hydropes. And this is one of its complications, okay. Poor gallbladder has been like a balloon, okay. Voila, as such. Look at this. This is very big, definitely more than 12 centimeters. Look at this. Oh la la. This is very big, very big gallbladder. This is the hydropes or the mucocele of the gallbladder. Okay. Here the gallbladder, okay, has been distended and the bile inside of it has turned into pus. So this is called empyemia. And it would lead to very polycystic fluid. Okay, let's see this. Right. All right. Voila. This is the mud inside, and as we said, the mud in such case is more likely to be pus. Okay, with technique of the gallbladder. Voila, look at this. It is turbid. Inside of it is turbid. This is another very grave uh, complication. This is the gangrenes, in which there is sloughing of its wall. So here we have part of the membrane is sloughed. Part of the membrane, look at this, it is sloughed, it has fallen inside of it. This is very dangerous. This is the gangrenous cholecystitis. It's very dangerous, and you have to clarify it. There you have a stone here. Okay, so this is calcular cholecystitis complicated with gangrene. So it is gangrenous calcular cholecystitis or acute calcular cholecystitis or acute gangrenous calcular cholecystitis. It's absolutely important to be this clear about this because this is very dangerous condition and the patient might not have this kind of pain that would suggest to you cholecystitis if he is diabetic, for example, as we have said before. So it is absolutely important that you notice this and you write it clearly in your report because this is a life-threatening case. Okay? So it is really very important that you write it and report it. Again, there is this sloughing of its membrane. Look at this. This is sloughing all around. Okay. This is a sloughing of the wall. All right. Okay. Let's see other complication. I think we have overlooked it. Okay. Here. Okay. It's important, of course, in the empyemia and the gangrenous. If this patient is ill, this patient is ill, especially in empyemia. Okay, he's gravely ill. He's got an abscess. Okay, so I think there was a picture for perforation. It's not. Perhaps it's not okay. Perhaps it hasn't come up yet. Okay. So back to our list. Okay, the gangrenous cholecystitis. Okay, this is here. Okay, here this is the gangrenous and this is the stone. Okay, this part of it is sloughed. Look at this. Okay, be partly, not all of it. Okay, so it is also important to notice it. Here we have another complication that is the emphysematous cholecystitis, that was the gas-forming organism, okay, form air. And how would air appear in ultrasound? Let's see. We make reverberating shadow as such. Voila. This is reverberating shadow, okay, that is of the air. It is mixed as such, and it looks like the duodenum. And that's why it's very important if you do not see the gallbladder, okay, and the patient has told you that he is actually fasting and hasn't removed the gallbladder, that you would say that you have not seen it. Do not just overpass it and say, okay, it's contracted, okay. No, just try it in order for it to be seen again, follow up, schedule another visit so that it can be investigated because the patient might be diabetic and might have this condition, okay, and this might be overlooked as in contracted or something, and he might has this very grave condition, okay. If sometimes you can see it clearly as in here, just part of the wall, okay, has this air shadow. Well, it rests the same whether it is in the whole of it or just in one part, okay. If he has air in the wall, then it is emphysematous cholecystitis, okay. Again, here it is more evident. We have here air shadow, okay, in the wall, so this is emphysematous. And you can order X-ray or CT to be more sure. Now let's see this real time. Voila. Now it has this air bubbles inside and it is moving. Although I did not move the patient, didn't show she's decubitus, but it's moving, resembling soda can or sparkling water. Okay, you can see the bubbles moving as such. And of course, you see the classical picture, thick gallbladder. This is acute cholecystitis, complicated with a gas-forming organism, and or we can say acute emphysematous cholecystitis. Okay, it's very important that you mention the complication because they are all three. This is how would it appear by the X-ray. Okay, this is air in the wall of the gallbladder. In the CT, it would appear as such. Of course, the air would appear jet black, and it is very evident that it is in the wall. Okay, voila, this is the perforation. We have perforation in the gallbladder. There is abscess, perforation, and of course there would be fluid around it, as in the previous picture there was an abscess. Look at this perforation. This is the perforation. This is the complication. Here there is the hemorrhagic cholecystitis in the trauma cases. Okay. All right. So the complication, as we have seen them, let's do some wrap up. Okay. Let's wrap up things. Okay. What have we discussed so far? This is the acute cholecystitis. Acute cholecystitis picture. Let's round it up again. Okay. All right. Now, what are the acute cholecystitis main signs by ultrasound? Of course, first the positive Murphy ultrasonographic sign. Tenderness elicited by the probe. Okay, what else? That has started the whole story. The impacted stone at the neck. Okay, as we have said, it might not be impacted, just the stone is present. Okay, might have moved, but usually the impacted stone at the neck or the cystic duct start the whole sequence. And then let's remember together what will happen. The gallbladder will distend. This obstructed, it will distend more than 4 centimeters in width. And then the wall would do what? Will hypertrophy. So I have thickening of the gallbladder more than 3 millimeters. And then this thick wall would call for more blood supply. That is hypervascularity. And then this is would ooze and leak around it, causing polycystic fluid. Now let's count 1, 2, 3, 4, 5, and 6. Voila. These are the 6 cardinal signs of the ultrasound. As we have said, none of them is mnemonic on its own. It is the combination along with the clinical picture. Now, let's see the complication. What are the complications? Okay, the gallbladder distend too much, causing the hydrops or the mucosa if it has increased over 10 or 12 centimeters. Okay, other thing is the empyema. It has turned itself into an abscess. You see mud inside, okay? And this mud here, it will be pus, and the patient is critically ill. This patient is ill, he has an abscess inside, okay? Then the slough membrane. If I see slough membrane inside it, this is also grave. This is the gangrenes. But no, don't forget that the patient might not be suffering too much if he is diabetic. Do not forget this probability, okay? And then there is the perforation, okay, and formation of abscess around it or pericystic fluid, and then there is the emphysematous or gas-forming organism. I would order, if I am suspecting, I don't see that this reverberating shadow clearly, and order X-ray or CT, and I would see them clearly. Okay, so this is what we have discussed so far. All right, let's continue. Okay, so far so good. Yeah. Now we have finished these. What about the chronic cholecystitis? Okay, when this condition, the gallbladder stones, okay, cause inflammation of the gallbladder, and it is repetitive, it would cause chronic cholecystitis. Okay, How would I see it by the ultrasound? Let's see. First, there is the thick gallbladder wall, uniformly thick and echogenic, as we have seen. But it can also appear by the WIS. What is the WIS? Wall echo shadow, and we see. Another thing, the porcelain gallbladder. But forget about the xanthographitis polycystis. Most probably you will not encounter it. Now, let's look. Here we have the thick gallbladder wall. We have here thick gallbladder wall, uniformly thick, along with the stone. So this patient has chronic calcular polycystitis. Chronicity as in by, suggested by the thick echogenic gallbladder wall. Okay. All right. This is it. The thick gallbladder, the traditional way how it looks. Okay. The porcelain gallbladder is when there is calcium deposition, okay, in this gallbladder, in this chronic calcular gallbladder, okay. So this will produce shadow as such. This is the calcium, okay, in the wall of the gallbladder, thickened wall, and so this will mask the gallbladder, cast its shadow over it. You have to take care of this condition because this is precancerous. Has to be mentioned, okay, because it is precancerous in 25% of cases. Okay, now the wall echo shadow complex here. We have two parallel hyperechoic lines along with hypoechoic in between. Okay, again, two parallel lines, echogenic, okay, with hypoechoic line in between. Voila, this is the WIS. Here it is. This is wall echo shadow. Okay. Okay. Here, is it WIS or porcelain? This is porcelain. Why? Because it is all over the place and it casts this huge shadow. Okay. All right. Now, in order to differentiate what is the wall echo shadow complex list, the pattern of the chronic calcular polycystitis, and the porcelain, which is a very grave, as we said, condition because it is precancerous. Okay, the wall echo shadow complex, this appearance happens when the gallbladder is contracted over the stones. Okay, yeah, there is distal acoustic shadowing in both, but here we have this form of the wall. Okay, there is this two hyperechoic lines with hypoechogenicity in between. When the porcelain gallbladder, no, there is calcium in the wall and distal acoustic shadowing in it. Okay, so this is different. Here we would say in the report that the gallbladder is contracted over stone. Okay, but in the other we'd say that this is porcelain gallbladder. Okay, let's see how the porcelain gallbladder will appear. This is the contracted gallbladder of stones. I can appreciate the two hyperechoic lines with echo in between, okay? And there is distal shadowing of the gallbladder. But here, no. Here we have, okay, here, okay. Yeah, here we have the porcelain gallbladder when there is calcium deposition at the one echogenic line and nothing underneath it. So yeah, this is just the porcelain gallbladder. Look at this. This is very evident. This is echogenic line with nothing underneath. So this is the porcelain. Of course, if I am in doubt, I will order another thing in order to be absolutely confirming. We can use the X-ray, which is more easier and less radiation dose, or the CT. Here there is focal deposition of the calcium. Also, this is considered to be porcelain. Okay, here there is by CT. It is very evident by CT. Look at this by the X-ray. The calcium is deposited in the gallbladder as if it is drawn by it. Very, very evident. Okay, so this is important in order to differentiate and to be precise. Okay, so we have finished the chronic polycystitis, the traditional chronic polycystitis, the echogenic line. The WIS is contracted over bladder, it's wall echo shadow, the wall echo shadow, and the porcelain gallbladder that we can verify by the X-ray or the CT. Now the polyps and the adenomyomatosis. Okay. Now, these are the polyps, the cholesterol polyps that are in the wall and they are not mobile. Okay, look at this. This is the polyp. Okay, here. This is the polyp and it's not mobile. Okay. The important thing, it does not move with the decubitus, so it is not floating stone or something. All right. This is polyp that's attached to the wall. Okay, can make sure by the Doppler. If we have managed to see vascular flow, this is of course not slow. This is a polyp. Now, this is a polyp by the CT. Okay, soft tissue shadow inside. Now, this is evidently the polyp. This is the soft tissue inside the gallbladder. Now, we have to make sure, is this cancerous or not? These are the criteria that suggest the risk of malignancy. What are they? Let's remember them by the S and the 6. Here, if the size is more than 1 centimeter, then there is high risk of malignancy. If the patient is more than 60, the singularity, okay, if it is single, then there is high risk of malignancy. If there is associated with a stone, if there is rapid change in size, okay, it's growing rapidly. If the RI is more than 0.6, okay, so these are the risk malignancy, okay. The criteria that I would suggest that this polyp has high risk of malignancy, and thus I would make the patient make close follow-ups and be a little worried in order to make close follow-up. Okay. Here there is a cholesterol polyp, and if it is multiple, we would call this cholesterolosis, or it would look like strawberry gallbladder, just a name. The important thing that it is this condition is the cholesterolosis. Okay, and yeah, it's gone. It is gone. We have this the cholesterolosis. Yeah, there's nothing worrying about it. As we have said, the risk of malignancy is with singularity, single polyp. But it's being multiple, no, it's comforting. There is no high risk of malignancy. Okay, all right. Let's move to another entity, the adenomyomatosis. Okay, the adenomyomatosis. From the name, we can say that it involves two things: the columnar epithelium and the muscles. Myo, muscles, the adeno, that is the columnar mucosa. It has two patterns we would see in the ultrasound, whether it is the hourglass patterns, there's constriction here in the middle, or it is fundal, involving the fundus. Okay, let's see this by the ultrasound. Okay. This is the hourglass appearance. Okay, this is the hourglass appearance. Of course, we can say that this is a mass. It is differential diagnosis. Okay, it is for differential diagnosis. Here, constriction in between. This is the adenomyomatosis, the hourglass. Okay, this is involving the fundus, adenomyomatosis. Okay, the fundus looks weird. This is the adenomyomatosis, which we would suspect it. Okay, again, the fundus. All right. Now there is another pattern of adenomyomatosis. Okay. Here, if we are in doubt that this is emphysematous, and these are the air shadow. We can order CT or X-ray or refer to the clinic of the patient. Okay, look at this. This is the third pattern of adenomyomatosis. Okay, the third form here, picture. Okay, so we have finished the adenomyomatosis and the polyps. Now rest the carcinoma. Okay. Now the carcinoma, voila, we have soft tissue shadow that's irregular, or we have neural wall thickening that is irregular. Okay, you have polyp that has high suspicion of malignancy that's more than 1 centimeter, that is non-uniform, that's rapidly changing in size. Okay, that's highly vascular. By the Doppler, look at this, there's high vascularity. Okay, and by the CT, you have soft tissue mass non-uniform. Okay, so all of this suggests this might be cancer. In this case, as we have said, there is soft tissue mass, okay, like polyp, but with a stone. This increased the high risk of malignancy, and in fact, this patient proved to have gallbladder cancer. It is important to note the risk factors. Here, it is vascular. It's more than 1 centimeter. Look at this. This is huge. This is cancer. Okay, this is adenoma. This is invasive cancer. Okay, so we have finished the. Okay, this is cyst. Cyst in the wall of the gallbladder, like the renal cyst or hepatic cyst. Okay, cyst in the wall of the gallbladder. Okay, so this is finished the abnormalities of the gallbladder. Okay, let's see what will happen when we have a case of the gallbladder. Of course, we'll look at it first. Is it normal? Does it have variance or abnormalities? Okay, check this. Does it have stone? Well, if the patient has a stone, is it inflamed? Is it complicated? Is it acute? Is it chronic? How would it look? Okay. Is it non-calcular cholecystitis? Okay. If it is complicated, what is this complication? Is it perforated? Is it hydrops? Is it chronic? Is it lymphedema? Is it emphysematous? Okay. And others like adenomyomatosis and the polyps, and of course the cancer. Okay. This is the miscellaneous stuff. All right. So let's wrap up the lecture with this little quiz, okay, to verify that we have undertaken everything. Okay, now I want you to think about everyone. Give yourself a sec, okay, and think about what is this? Is this a fold or a septum? Helping you out. Voila, this is incomplete, so this is a fold. Bravo. Now, give yourself mark for every correct answer. Okay, hopefully you get them all right. So this is the first. Let's look at this. What is this? Huh? Yeah, this is a stone. Where is it? Absolutely correct. It's in the virgin cap. Bravo. Next. Okay. Huh? What about this? Does the patient have stone shadows here? No. It is merely the artifact or age artifact. Okay. This is a trap question. Okay. What about this? The patient has what? Has multiple septi, and this is multiseptated gallbladder, as in the honeycomb appearance. Bravo. Okay. Do we mention that the patient has septum or not? Absolutely correct. Because liable for complication, it's worth mentioning. What about this rare condition? Yeah, it is. Outpouching and skull diverted. Bravo. Absolutely correct. What about these little things? These are multiple gallstones or confluent gallstones with shadowing. What about this? Huh? What is this? This is a floating shadow. That's most probably formed by what? Huh? By cholesterol. Absolutely correct. Okay. What about this? Fluid level with white line. Absolutely correct. This is milk of calcium. And I would verify by X-ray. Bravo. Or CT. More simple X-ray. Okay. What about this? This patient has, I will tell you, he has history of acute pain. What would you suggest? The presence of stone with acute pain and this mud or pus and the thick wound and this fluid around it, all of this is acute calcular cholecystitis. Make the diagnosis complete. Acute calcular cholecystitis. What about this? Yeah, I want the diagnosis to be complete. This is what this is. Yeah, acute calcular. This is calculus and acute cholecystitis complicated by gangrene or acute gangrenous cholecystitis. Bravo. Bravo. Mm. What about this? Uh, yeah, again, acute calcular cholecystitis with gangrene. And there's a stone. That's why I said acute calcular. Bravo. Okay, what about this case? What do we see here? Okay, yeah, this is porcelain gallbladder. Now, how to differentiate again between porcelain gallbladder and the contracted over multiple stones? In a porcelain gallbladder, as we see here, we have one layer, one echogenic layer, as we have said, casting shadow underneath it. But in contracted over stones, we have three layers that we see casting shadow. But we have three layers: wall, echo, shadow, and then the shadow. Okay, but here we have one echogenic layer, that is the porcelain. Okay, bravo. Okay, let's continue. Next. Okay, what is this? Multiple lesions attached to the wall. Yeah, that is multiple polyps. In other words, cholesterol. Bravo. Okay, what is this? This is a young patient not suffering much. Yes, adenomyomatosis. Okay, that's the hourglass pattern. Okay, what about this? Will I make the patient worried or not? We have here a polyp, okay, that has vascularity and that is associated with a stone that is single and that is more than 1 centimeter and associated with stone have more than one risk for malignancy. So we have here a polyp that is really concerning and it might be cancerous, okay, and this is the gallbladder carcinoma. Yeah, bravo. Thank you. That was all for the gallbladder. I hope that you have gathered it all and thank you.